The next session for today's, may I have the details of the next topic, please? Dr. Chintan, have you joined? Hello. Hello. Hello, I have some technical issues. Hello. Hello.
Yes, sir.
Hello.
Yes, sir. You can tell the topic and just the name of the speaker. You can.
I have some technical issue right now. Hello. Dr. Sandeep Rai, I have some technical issues. Can you initiate the first topic? Yes, now, yes. So our next speaker is Dr. Navneet Agarwal, and he is a consulting diabetologist at Gwalior and a chief diabetologist and director in Obesity Thyroid Center, Gwalior. He is CEO and founder of DNA Sugar Clinics. And his introduction is such a prominent and stalwart that his introduction will take a very long time, but some of the prominent awards, he has received Healthcare Excellence Award for improving affordable access to diabetes care 2022, Times of India Healthcare Icon 2017, Distinguished Diabetologist 216, Best Youth Dr. Gwalior 2016. And he has got many publications at his name. He is the editor of Annals of Diabetes and Clinical Complications. So without taking much of your time, over to Dr. Navneet Agarwal, please.
Thank you, sir. Thank you, chairpersons. Am I clearly audible?
Yes, yes.
So my screen is visible?
It is blank. It is visible, but it is blank.
Now it is, the slides are visible?
No, slides are still not visible.
They are not visible?
No.
But I have shared the slides. They're not visible?
No. Can anyone, Nishad, can you help us for the screen share by Dr. Navneet?
Are they visible now?
Yes, now they are visible. Yes.
Okay. So thank you, chairpersons. And at the outset, I would like to thank the organizing team of Diabetes Care for inviting me and giving an opportunity to discuss the democracy in diabetes. The word democracy is derived from two words. Demos means the people and kratos means the rule. So the democracy is by the people, for the people, and of the people of the country. And our constitution is committed to secure justice, liberty, and equality for the people of the country. But our constitution does not explicitly define the right to health. So though the several references has been made about the public health, and in landmark ruling, the Supreme Court has reaffirmed that every citizen has right to health. So the right to diabetes care or right to euglycemia is under this obligation and should be provided to every citizen in appropriate and affordable manner. If we see the diabetes landscape in India, we know that the occurrence of diabetes does not respect the boundaries of age, gender, socioeconomic status, geographical boundaries, or location, language, or state. So it is prevalent in all the areas. And we know that India is home to 77 million diabetics, and almost around 200 million pre-diabetics are in waiting. And this is the usual journey of a diabetic patient. When a patient is being diagnosed as a diabetes with symptoms or even asymptomatic, he goes into the shock or the denial phase. And he follows either the Google, WhatsApp, or relatives' advice and tries to control or normalize his blood glucose with the home-based remedies without any scientific evidences. Here he misses an important opportunity of diabetes remission or reversal. And majority of the patients, because of lack of awareness, accessibility, and the accessibility to the quality diabetes care, and lack of funds or the lack of affordability, they does not take the proper treatment. And even if they consult, the adherence and the compliance to the treatment is poor, and which is an important issue, and which results in a poor clinical outcome and the higher A1Cs. Around 80% of the patients, they realize their diabetic status when they cross the stage of pre-diabetes, and here they miss an important opportunity of remission. And about 70%, 75% of Indian population has unlimited access to a quality diabetes care. So there are some fundamental challenges in achieving the target A1C in Indian population, like accessibility. Almost around 95% of people are from tier 2 cities and beyond, where only 7% of specialists like endocrinologists and diabetologists are giving their services. So this is leading to a poor patient-provider ratio. And about 70% of the people or the diabetics are unaware that this can severely affect their vital organs, and only less than 10% of the patients has met a diabetes educator in their duration of diabetes. So, and affordability, it is another major challenge, as the majority of the patient has to pay from their pocket for the medicines, for the consultation, for the investigation. So sometimes the affordability is a challenge in achieving the target A1C. So the net result of this is that almost around 3/4 of the Indian population has a poor glycemic control, and of them, almost around 1/3 had a microvascular complications. And this is the data from ICM and India study, where around 60% of the patients has not checked their A1C in last 1 year. So what is the need of what India needs? We need to democratize the diabetes care, and we need a care program which should Sarvodaya, that is for everyone, but it should include Antyodaya, that is, it should provide benefit to a last person in the row or the weakest section of the society. And even our constitution highlights the 3 values: justice, equality, and liberty. But when we talk in terms of diabetes care, justice implies offering correct screening, diagnosis, and therapeutic tools to the patients who are in need. Equality implies access to diabetes care to all without discrimination on any ground. And the liberty implies the patient's autonomy and patient-centered care and liberty to choose the type of care. But the challenges are many, and the challenge is to achieve this target A1C is a poor patient-provider ratio in the country, where a burden is expected to rise due to the rapid changes in the lifestyle and demographies. So the prevalence is increasing day in, day out. Though the government has launched the National Control Program, wherein thousands of national NCT clinics, the medical officers, the doctors, and the paramedicals are providing their services. And besides this, multiple private diabetic clinics, including the corporate hospitals, individual centers, the diabetic clinics, they are providing the care. But do you think that this is sufficient in a country where half of the patients of the diabetes are undiagnosed, where the incidence of new cases is highest in country? So what is the new hope? And the hope is from, in such scenario, we can have a hope from the digital technology, wherein the digital technology based solutions in combination with the traditional physical care can be an answer to many of the challenges of the diabetes care in the country. Even globally, the Lancet Commission has mentioned a mission-oriented digital approach to the digital health, which aims to diffuse its benefit equitably, economically, and in a democratic way. So the digital transformation in health are human right based and support the universal health and health coverage and the health for all. So as globally as well as in India, we know that India is the second largest mobile phone consumer worldwide. And by using the digital technology, we can have improve in the delivery of the diabetes care, including the health promotion, prevention, primary care, and even the specialized care in India can be provided through the digital platforms. And let's see the clinical evidences. This is the data from US, where a use of AI virtual health assistant has showed that just by use of this has showed a significant reduction in A1C, and which was sustainable for 2 years. And this is the data from the real world study from the country and from the India, wherein 7,000 plus patients who were using this digital or the smartphone combined healthcare diabetes care ecosystem, and they have a significant reduction in the preprandial and postprandial blood sugars in the 45 days. And this digital technology or the digital ecosystem is not only helping in controlling the hyperglycemia, not only helping in achieving the euglycemia, but it is also helping in reducing the hypoglycemic events, because we know that when there is no fear of hypoglycemia, we can achieve the target A1C any patient. So we always fear a hypoglycemia, as Dr. Rudy was discussing, that we should be very cautious about avoiding the hypoglycemia in the older population or in the elderly population. So we always fear a hypoglycemia. So even the digital technology or the digital ecosystem is helping to prevent hypoglycemia, and there was a significant 80% reduction in the hypoglycemic events in the patient who use this digital smartphone connected ecosystem. So though there are many multiple solutions in the market, and patient can choose from anyone from them, and depending on his or her need, so he can choose like what type of the patient's profile or patient's comorbidities and patient's access to the digital technology. But there are multiple solutions available in the market. So in nutshell, and to summarize, if we see the democracy in the diabetes can be achieved through a digital transformation, which will help in expanding the geographical access to the diabetes care, which will help in increasing awareness to the patient, so they are more aware about their diabetes care. They can have a more they are more vigilant about the self care. They should know the targets of their fasting and PPG. They should know more about the dietary plan. They have a more knowledge about their nutritional intake, the carb intake, because like in India we know that the major challenge is the dietary intake, and to explain them, because like we are majorly the cereal based, or the diets which we are taking in the across the country, they are all more carb based. So it will improve the awareness about the nutrition, about the exercise, about the physical activity, because we know that the lifestyle is a major pillar of managing type 2 diabetes. And these digital transformations will also help in improving the patient provider ratio, wherein they'll have less burden of the patients on the providers, wherein they can use the digital technology, EMR based solutions, the appointment based systems. So this will help the providers also, and will help in reducing the patient provider ratio. It will reduce the providers burden also. And this digital technology, the use of this digital technology, we can reach to the last person in the row, or we can reach to the weakest section of the society, as we can expand the geographical access to the care. Because we know that the patients who are staying in the rural areas, patients who are staying in the far reach areas, they have to travel to the cities, they have to travel to the major towns to consult a specialist or a diabetologist, and to fetch their medicine and to get their investigation. So like by just the digital technology, we can have an access to those rural areas where the lack of services are there. We can really change the entire system of diabetes care. And finally, with this use of technology, like we are reducing the cost of transport, we are reducing the cost of waiting, we can reduce the economic burden, and ultimately, at the net result of that, we can improve the clinical outcomes in our patients of country. So thank you very much. Let's join hands in serving our nation and its citizens. And thank you all for your significant contribution in making India as a diabetes care capital of the world. And this philosophy of the Gandhiji, I think, Sarvodaya through Antyodaya, which means the development of all to the welfare of the weakest section of the society, will definitely help us in guiding the diabetes care for the future in the country. Thank you very much for the patience.
Dr. Chintan Vyas.
Yes, it was really a very good enlightening lecture. Now I would like to invite the next speaker. Please start our next speaker is Dr. Bharat Sabu, who is a chief diabetologist and director at Prayas Diabetes Center, Indore. And he has lots of accolades under his belt. He is trained in data science for precision medicine from Edinburgh University, scope certificate for obesity management, advanced postgraduate course in diabetes by ADA, Chicago, USA. And he is a postgraduate trainee in endocrinology, diabetes, metabolism conducted by European Society of Endocrinology. Is life member of ESC and RSSDI with membership of ADA, ICE, AAC, ESC. So he has lots of accolades, as I have already mentioned. I would like to invite him for the next talk. Thank you. Over to you, Dr. Bharat.
Good afternoon, everyone. First of all, I am thankful to the respected chairpersons for giving my introduction. my elder brother, Dr. Banshi Sabu sir, for giving me this opportunity here to present this topic, which is very close to my heart. Dr. Manoj Chawla sir, for giving me this opportunity to be here. And also, I would like to thank my elder brother, Dr. Navneet Agrawal, for here being with me. So the topic which has been assigned to me today is, can newer technologies alleviate the burden of diabetes? So in next 20 minutes or so, I will like to talk about this because this is a really interesting topic and this is something very new to us. The flow would be a background of diabetes, the burden of it, and where the technology is heading. Then what the studies say, there are a lot of them, but we will talk about few of them and the conclusion. To begin with, I would like to begin with the alarming diabetes statistics which we have, because diabetes is a really alarming situation, we all know. And it affects a day-to-day life of more than 225 million people. And it is set to affect the 10% of world population by 2040. More than 12% of global health spending is on diabetes. And the diabetes-related complication led to 4 million deaths in 2017. One death every 8 seconds. It is more dreadful than any disease. Now, the worst part is 46.3% patients are still undiagnosed, and this is the expected increase in the number of diabetic patients by 2035. So we are going to deal with a lot of patients, I would say. Now, there are certain hidden costs also which are there associated with diabetes. We all know about this, and 60% of those with diabetes, they say that they have a complication, one point of their life where they need to work upon it. And the survey respondents who have sometimes gone without diabetes care, those who cannot afford it, were 45%. And this is the Western world. You can imagine the scenario in our country, which is already very poor in terms of healthcare resources. Now, this is again a data which is very startling, and I read it. It was terrifying that almost 9 in 10 younger adults with diabetes delayed healthcare during the pandemic because it was very difficult to keep the routine appointments. It was also difficult to take the prescribed medications, especially insulin. The urgent care was not available most of the time, and they were needed to get a COVID-19 vaccine, but they were delaying the healthcare due to all the factors which were there among and around us due to the COVID-19 wave. Now, where the technology is heading, because today's topic is really very interesting and this is a very vast topic, but I would like to point out few things that this is a really interesting graph which you can see on your screen. The life expectancy has gone up gradually. We first developed bacteria, then we came up to the human genome, and the life expectancy gone up. But as the advent of the ways to communicate or the means of physical communication and the communication, verbal communication improved, we also saw an increase in overweight and obesity. And you can see a robust increase of around 30% in overweight and obese patient from 1950 to around 2000. So this is a really alarming situation because all these obese and overweight patients will soon be going to become type 2 diabetic patient. Now, what is this actually all about? The diabetes technology, how it impacts us? Because we have our diabetes prevention goal, then we have a diabetes care and management goal, and then we want to do diabetes research. Then diabetes prevention, we need to have a hard to reach population which we should target. Screening should be our prime emphasis. Then health literacy should be increased, lifestyle changes, public health intervention should be done. Regarding care and management, a lot of things need to be done, especially in terms of the psychological well-being of patient, the biomarker monitoring, glycemic control becomes the utmost and paramount importance. We need to have a health system and economic model also, and a patient HCP relationship should be established. And all these two factors are very important. But the third factor we should not ignore is the diabetes research, where we should have data sharing, open data, e-ethics, data security, so that we can generate the new research hypothesis, we can find out the innovative markers of risk and pharmacovigilance. So this is the place where AI and big data came to play, because they are the thing which can provide us this much data. And this data will come from the digitosome. This is a very new term, like the digitonians. So it is wearable, smartphone and app, smart medical devices and sensors, especially social media also is a part of digitosome. Online communities, telemedicine, smart drug and e-health record, these contribute to this digitosome. So this is the new ecosystem which is developing in and around technology. Now the technological availability will further enhance, because all these things which are there, we are hearing most of them and using most of them. Smart ECG devices which can detect arrhythmia, even the BP machine now can detect arrhythmia, flash glucose monitors, smart drug which are regime compliance is of maintenance. So regime compliance is maintained and the physiological response to treatment and the body temperature is also taken into account. There are a lot of apps, number of apps is huge, which can control of connected devices, medical records, telemedicine, social media, and online platform. Then we have the smart weighing scale. Almost most of the patients now have smart weighing scale, which is connected via Bluetooth to their phone, and it gives them a daily indication of their fat percentage. Smartwatch is not new. Almost every second person is wearing a smartwatch these days. Artificial pancreas is the new word in the town, and it is talk of the town, and the results are very good. Smart BP monitors and smart contact lenses, which will be coming with the Google, they will sense the glucose level. And mind you, the Apple Watch 8 will also have a glucose sensor inbuilt, but promising. So smart socks are also there, which can sense the temperature, inflammation, infection, and amputation prevention could be done. Now, wearable devices, sensors, smartphone apps, e-health records, and data mining, telemedicine along with online communities, they provide this big data to the artificial intelligence, machine learning, and deep learning. So this all creates a self-care, Internet of Things sort of pack, where you take food intake, you have a blood glucose device which checks for your blood glucose post the meal. Then it suggests you some aerobic exercises, then it suggests you dosage and injection. And all this is driven through the self-care IoT pack and a self-care app, which is connected to a web server. So the doctor is potentially bypassed and you take control of your things. Now, artificial intelligence, as I have told you, with machine learning, will contribute the most to the diabetes care. Let it be the disease itself, healthcare professional, or the healthcare system. We all would be benefited by these things. Now, coming again to this thing where the goals and the patient reported outcomes are seen, the patient and caregiver, they are integrated, and they are integrated by various means: the diabetes care team, health coaching, telehealth, big data and analytics, because all these which contribute to the HbA1c goal of less than 7.5, which will decrease the rate of complication. Now, how it would be done? The diabetes education, behavior modification, and health coaching would be done on smartphone. It is already started. Food logging, dietary counseling, and demonstration has already started. Medication reminder, prescription refill is a very common thing these days. The telehealth appointment and patient portal is very common. We all use it. Telepharmacy is also very common. There are lot of diabetes forums, tell you, on social media. Most of them are flooded with wrong information, but there are lots of diabetes forum. Remote monitoring also there, which we are using with the help of digital therapeutics. Exercise and weight tracking and engagement is also there with the smartphone. So your smartphone becomes your tool to manage your blood glucose values, because there are meters which can be connected with the smartphone directly, and then they can fetch the data and send it to your healthcare provider. Now, this interoperability will improve the digital medicine. But how? The AI and big data, it will give the algorithms which will structure the data, which will validate the data, and then they create the trust in digital technologies, which will in turn improve the research, which is the real world research regarding diabetes. They can create newer research hypotheses. They can enable remote development of analysis script. And then we can have medical communication, which is easy way of sharing information. Patient can have it on their phone. It is very easy. It will again avoid medical errors. A printed prescription is much better than the written one. everyone will agree to it. It will reduce documentation burden and it will empower patient. And then it will set the international collaboration, because suppose me and Dr. Navneet wants to share data, we can share our data. Me and my friend living in UK wants to share data about type 1 diabetes, we can very easily share data amongst ourselves. So international cooperation will pave way to more research. Now, research. What are the already established researches and what the studies are going to say to us? This is the robust number of published digital health efficacy studies from 2007 to 2017. And you see the number keeps on piling. It is increasing like anything, the number of published digital health efficacy studies. Now, what this research will do, it will pave way for a better future, because there are lot of companies involved in these patient-centric digital diabetes ecosystem. There are connected device manufacturers who have BGM, CGM, pumps, pens. There are app provider which have logbooks, education, and SCP solution provider. There are data integrators, logistics, online communities, above all data management solution provider. They are coaching provider also. There are some people who are AI enabler, database provider, and solution developer. So all these companies are doing too much of research into this diabetes technology. So actually, to begin with, what the studies say, this is a very recent study for the stem cell based organ on chip model for diabetes research. And it says that we can do a stem cell based chip, and it is actually going to help our diabetic patients via this pathway, although it looks actually very tricky, but the ultimate endpoint is improvement in the beta cell function and beta cell mass. So it is also giving rise to neogenesis. So it is something which is very promising in terms of stem cells. Now, this is again a paper from BMC endocrine disorder, where they were talking about impact of technology-based intervention for children and young people with type 1 DM on diabetes self-management behavior and prerequisites. And they have shown that the behavior improves when we involve technology in it. Then technological advances in shaping diabetes care is another paper which talks about the same thing. And it tells us that the global, regional, and national burden and trend of diabetes is although increasing, but it can be taken care by with the help of technology. Now, there is this very recent study which reveals positive impact of flash blood glucose monitoring on blood sugar and quality of life. And it has been shown that the flash glucose monitoring, which is used by almost half of people living with type 1 diabetes patient in UK, because it is reimbursed there, it helps to lower their blood glucose value. In India, again, we are going to soon have a low cost version of this, and that will be a boon for our patient. Now, there is again a paper on effect of technology assisted integrated diabetes care program. This is something very unique, where technology is assisting the integrated diabetes care on cardiometabolic risk factors in patients with type 2 diabetes in Asia Pacific region. The JADE program it is called, and it has shown that the number of clinical events do not change, but it do reduce the cardiometabolic risk factors in patients with type 2 diabetes. Now, the closed loop pump is the biggest revelation of all, and it increases time in range substantially. It improves the quality of life. It reduces the diabetes burden and gives more freedom to patient, improves the sleep quality, and reduces the anxiety of patient. So, is there any data? I was searching that technology influences the eating habits. Yes, because we are connected with our CGMs, which are connected to the smartphones. And before eating, after eating, we can take measures of our blood sugar values like these two people are doing. And they can be very watchful about what they are eating. So it is again possible to have a motivation in form of sharing food snap on Instagram and Facebook, because it has grown into a worldwide phenomena. The moment I eat anything, I put it on Facebook or Twitter, and that inspires others to eat healthy. According to a Choosy Modern Food Trend Pattern report, it is seen that 39% of respondents claimed that social media influences their current eating patterns. So 40% are being influenced by the social media. And the generation Y, which is the most recent generation, was influenced 70%. So this is something very startling. The young people are startled to see others eating, and they try to copy them up. Now, technology as a nutritional intervention, when we see, it provides a promising new avenue for delivering engaging and successful nutritional intervention, because as we have seen, the generation Y is most impacted by what they see. So nutritional intervention will also work well with them if we target them right. And in a recent meta review, it was found that technology-based intervention can also have positive effect in treating health domains, including substance abuse, mental health, diet modification, and physical inactivity. Now, this is a very interesting abstract which shows the impact of CGM with low-carb nutritional counseling on HbA1c values in type 2 DM. And it was surprising to see the A1C decrease by 0.41, and significant improvement in HbA1c was there, which was achieved without increasing the medicinal cost. And the CGM device were taken positively by the people who took it. Now, something like that, me and my wife did, the impact of ambulatory glucose profile on HbA1c and dietary habits. This was published in Endocrine Abstract, and we were able to see there was a sharp reduction of HbA1c of 2.2 in AGP group. But the important point was that 72% of the persons who were in AGP group, they stopped the intermeal snacking, which is a very common pattern in our city, Indore. So the intermeal snacking was stopped by 72% patient in AGP group as compared to 38% in non-AGP group. Now, moving forward, there is a study which reveals the positive impacts of flash blood glucose monitoring on blood sugar and quality of life. So researchers compared the finger prick to the flash glucose monitoring, and then they found that the flash glucose monitoring improves the quality of life and the sugar values also. This is again our paper which we presented at EAC, and it is an impact of regular teleconsultation on drug compliance, patient follow-ups, and A1C value in diabetic patients from central India. And we saw that the patient, those who were on digital therapeutics, had a better fall in HbA1c and had better anxiety scores as compared to the control arm. So this digital therapeutics not only helps them to reduce their A1C level, but it also reduces the anxiety scores and it alleviates the fear of the patient. This is again a very recent article, which I am humbled to share that we did it together, Dr. Abhishek, Banshi sir, and Aniket. The impact of a simple tool, a WhatsApp-based communication on insulin adherence and glycemic control in patients with diabetes. And we found that it improves substantially once we put them on a WhatsApp group, because then it sets a sort of daily reminder to them to take their insulin on time, and in turn it reflects in the glycemic control in patient. Now, again, a paper which says the utilizing Internet of Things and AI to enable twin precision treatment for reversal of type 2 diabetes. No talk on diabetes technology-based health intervention can be completed without this study. It is a research article, Type 2 Diabetes Reversal with Digital Twin Technology Enabled Precision Nutrition and Staging of Reversal, which is a retrospective cohort study. And it showed that the change in mean HbA1c was there at 21.5% reduction in the Twin Precision Nutrition program when patient was there for just 90 days. And there was a change in percentage of patient in range of HbA1c of 6.5 in just 90 days. And this again shows that type 2 diabetes remission and lifestyle medicine, a position statement which was given from American College of Lifestyle Medicine, was also saying that sufficiently intensive lifestyle modification are capable of regressing or remitting the type 2 diabetes. So with that, I would like to be on the key takeaway points. Diabetes technology is definitely the way forward, and it will definitely alleviate the burden of type 2 diabetes and type 1 diabetes in terms of complication in our country. Stem cells we are waiting for, but there are certain barriers to adoption which exist, mainly due to cost, sustainability, and integration of healthcare system. It has a particular potential to expand across the healthcare in undeserved population, because it is imperative to give them the quality healthcare what we desire, because without a quality healthcare, they will soon land up into the trap of complication. We need to work more for it, because we need to promote the clinical efficacy and the patient engagement in various programs which are there related to the awareness. And the future work in diabetes, we should focus on medicine adherence and lifestyle modification. And again, as a keynote, closed loop system definitely will replace the need for insulin management health tools in coming future. I can sense it. With that, I thank you all. As the Steve Jobs says, technology is the amplifier of intellect. So let technology be with us. Thank you.
Thank you so much, Dr. Bharat Sabu. Dr. Chintan Vyas, are you there?
Yes, yes. It was really very enlightening to know how technology is helping our patients and our healthcare providers to get into the groove and getting best result out of it. It was really very nice lecture.
So I suppose our next topic is by Dr. Pars Vas. Can I have his biodata on screen, please? Yes. It's a pleasure to introduce Dr. Prashant Vas. He is a consultant for diabetes and diabetes food medicine at King's Hospital, London, UK. And it will be very interesting to listen to him. So without wasting time, I straightway request Dr. Prashant to start his topic.
Can you hear me?
Yes, we can hear you.
Thank you very much. It's a great pleasure to be invited to Diabetes India. Actually, my last India trip was in 2020, which was a week or two before the UK lockdown. So I actually haven't traveled up and down since then. And it's been really very interesting to listen to some of the talks that have been done before me, and the explosion of technology and the understanding around technology in diabetes is really phenomenal to listen to and an eye-opener. Mine is a little bit more clinically oriented, so I suspect it fits in with the mixed bag theme of this session, and I'm going to talk about neuropathy, and I would kind of want to say it's not all doom and gloom. And I hope, I can try and sort of give some more insight into how diabetic neuropathy sort of works and what to do for the future. Specifically, talk more on neuropathy and pain management rather than diabetic foot. I think that's a slightly more complex and a wider session. And diabetic neuropathy is it's really a very common condition. It's probably the commonest neuropathy around if you discount alcohol-related damage. And it's not only that people lose sensation with it, it also brings with it significant amount of pain and distress, singularly the most important driver of diabetic foot ulceration at some point of time. Historically, we all thought hyperglycemia was the big driver of neuropathy, but more recently, we've come to understand, especially looking at people with pre-diabetes and when-controlled diabetes, and they've had very good sugars, yet they go on to develop neuropathy and neuropathic pain. We've come to appreciate the role of dyslipidemia, of insulin resistance in driving this neuropathy. So it's not just a hyperglycemia-mediated phenomenon, it's a multimodal neural injury. On top of that, of course, you can have mitochondrial dysfunction in these very, very active nerves. There is this concept that is now evolving, which hit comes first? Does the microvascular hit come or the metabolic hit come first? Undoubtedly, the microvascular element is intrinsically linked. You must remember the nerves supply the blood vessels. The blood vessels feed the nerves. So there's a very close interaction between these two elements. And hypoxia and microvascular injury has long been well established. These are sort of cross-sectional electron micrograph images just showing a significant amount of thrombus within an inflamed diabetic artery, which is also quite tortuous compared to a normal artery, which has that sort of very nice, beautiful flow within it. Diabetic neuropathy, I think we all know, most of us attending this conference, what drives it: diabetes control, the long duration of diabetes, high HbA1c. And we also spoke about the more preclinical elements, the insulin resistance, the dyslipidemia, etc. Some newer things that we come to appreciate: the role of vitamin D, the role of obesity, and a role of certain genes in driving the development of diabetic neuropathy. Of course, there are external factors, depression and anxiety. They're true, not etiologic factors, but they are intrinsically associated when diabetic neuropathy is prevalent. Any nerve is affected from diabetic neuropathy, but perhaps the most common one is the classical distal sensory motor neuropathy that we call it. Glove and stocking is what they used to call it when I was in medical school. A lot of the time it's pretty much stocking, but in a fair few, about a quarter of our patients, they are affected in their hands also. I've sort of tried to divide the symptoms into sort of negative sensory symptoms and positive sensory. And I think it's good to understand the difference between them. Negative sensory symptoms is a bit like your computer monitor just going off, versus positive sensory symptoms where your computer monitor just flickers and shows different colors. And that's important because down the line, often some of the therapies we have in place are to dumb down the positive sensory symptoms, and you can do a little less for the negative ones. These symptoms are very similar in a pathway of neuropathic pain, and you can get numbness or as a negative sensory symptoms. But some patients, when the numbness is above a certain threshold, find that uncomfortable. But hyposthesia, inability to feel anything, these are the negative side of things. But the burning, the tingling, the hyperesthesia, they are positive symptoms. Now, when they are present at a very low grade, you kind of notice them. They're not painful, and patients often don't report them. But when they're present to a certain threshold, or they're present more globally, patients are more aware of them. And when the brain starts processing them more at night, they come to you complaining of neuropathic pain. But it's a continuum from very early sensory symptoms to sort of development of neuropathic pain. And we're quite lucky in a way that the motor symptoms occur quite late in the stage of the neuropathy. Imagine if diabetic neuropathy caused considerable and significant motor symptoms. Not that it doesn't, it does cause considerable morbidity, but you get the sort of involvement of the smaller joints of the hand and feet. And one must remember, the foot deformities we see in our patients, it is a consequence of this sort of motor deformity. And sometimes you can have balance and gait problems in our patients. Often, and this is probably the most crucial slide I would like to talk about, people forget that neuropathy develops over a period of time. It's not that you didn't have neuropathy today or yesterday and you have it today. It's a continuum, and you can have no neuropathy to very subtle diabetic neuropathy. And I would like to highlight the far end. I think that's the one we often worry about in a clinical context, loss of protective sensation. That's really advanced neuropathy, by which time certain elements, in particular the feet and hands, you lose sensation to a degree that you are unable to feel and protect yourself. You can have earlier forms of more subtle neuropathy where you can still protect yourself to an extent, But once you get the loss of protective sensation, you really are at high risk for developing foot problems. You develop the deformities that can then bring their own problems. And what we do test in our diabetes clinics and in our risk assessment is this: we look for loss of protective sensation. We often do that using a 10-gram monofilament, but it does not pick up the more subtle forms of neuropathy. Many a times, you want to know when you see a patient is what is their 1 year, 2 year, 5 year risk of getting a foot ulcer. What else can you tell them? And if you want to do that, the monofilament is excellent choice. But there are other methods. The vibrotip that we sometimes use here in the UK. It's a key fob type device. It vibrates. And it's more like a tuning fork, but it just does one frequency, whereas the tuning fork will change its frequency. When you hit it, it goes up and then it can come down. And the neurosthesiometer, which is a mainstay in a clinic like ours, we tend to use the vibration perception thresholds, because you get a real value to what your patient can feel, not a yes and no, which a tuning fork or a vibrotip gives. And we know data that a vibration perception threshold of over 25 is equivalent. Lower values than that can indicate the presence of diabetic neuropathy. So please don't think a VPT below 25 is absolutely normal. It may indicate more subtle neuropathy, and there are age and gender decile normative ranges that one can refer to if you really want it. This was developed a few years ago by Jerry Raymond and myself when we wanted to explore what would be the safe way to assess really bandeau neuropathy in individuals coming into hospital. It's often very difficult to look for a tuning fork or a monofilament. And just doing a simple touch test gently, the amount of pressure would be the minimum pressure that you would use to change an app on your phone, for example, but not pressure that would move the toe, because that would be pressure rather than light touch. And we've shown this to be quite a useful method of screening for loss of protective sensation, really obvious neuropathy that would put people at risk in hospital of developing a pressure ulcer. But there's a huge choice of different equipment. We don't often use neurophysiology apart from in specific situation. The role of nerve conduction studies is to exclude differential diagnosis rather than confirm the presence of diabetic neuropathy. But I would like to say the corneal confocal assessments, which is looking at the cornea as a mirror for diabetic neuropathy, might be a modern development which we may in 10 or 12 years time, or probably even sooner in some settings, start using more as a more objective way of screening for very early neuropathy. Really keen to see how this technology evolves. A lot of focus on time and range and our CGM devices, but I really think that in the complication frontier, this is up there as a future tool. What would you do if you're assessing someone for in your clinic? I think if to look for neuropathy in your clinic, you've got to first think of the clinical question. If you're seeing a patient and all you want to know is do they have advanced neuropathy that you need to tell them about that would put them at a risk of future foot ulceration? If you want to do that, you can do any test for loss of protective sensation. So any of either the monofilament, the vibration perception thresholds, or even the standard scores, the composite scores that involve a bit of clinical examination. You can put that together and you can do one of these tests. But if you have a patient over there who's complaining of neuropathic symptoms, asking, doctor, what does this tingling and itching mean? I'm not particularly bothered by them. What would you do next? I think the first thing to do in this instance would still be assess loss of protective sensation. Because if they have lost that and it's abnormal, you know they have neuropathy and you can tell them, look, you've got neuropathy. We need to start protecting your feet. You need to make sure you get your feet checked, etc., etc. But what if it's What if it's normal? What if they're sensate? Does that mean they have no neuropathy? No, they could have more subtle, more forms of neuropathy. And often we can do a more specific test to look for that. Many of the different tests I showed you, there is no international consensus on what the best test would be. So you can refine your tests. But there is one time that I would get hold of a neurologist or a neurophysiology lab quite early, is if I see someone with atypical symptoms. Typically neuropathy and neuropathic pain comes in very slowly. But if I see someone whose pain has worsened over a few weeks, they've got significant motor symptoms, or they've got weaknesses, or suddenly they've lost weight, I would start to look at alternative. It might turn out to be one of these focal diabetic neuropathies, but it's important to make sure you don't miss a true neurological illness in someone with diabetes. So, of course, that's one caveat to this. So my halfway summary would be diabetic neuropathy is a big spectrum. It's not a yes and no condition, and it can be surprisingly asymptomatic. I'm sorry for that error there, even at its most advanced stage. And often we look for loss of protective sensation, and perhaps that's the most important thing. But was anyone saying something? I just heard something. But diabetic neuropathy is not the only thing that comes in the way of someone developing a foot ulcer. There are other elements, foot deformities from the neuropathy or from previous injuries. Peripheral arterial disease, a very key component involving, and that wheel is only going to get bigger and bigger as our patients age. We have older and more frailer patients coming through the door. But there's a host of environmental issues, footwear, trauma, cardiovascular, socioeconomic. All of this can drive the development of foot ulceration, which then increases the risk of amputation and the risk of mortality. So if you want to do a foot risk assessment, not just a neuropathy assessment, to assess someone's ulcer risk, you not only have to do an assessment of loss of protective sensation, but you also want to know what their pulses are, and if you want to look for deformities, because you would want to accommodate them. There are certain other key elements, whether they're on dialysis or not, whether they've had a previous ulcer or not. All this would put them at higher risk. But this would be the three components of any basic examination in our patients. In the UK, we use this traffic light system where every patient gets an annual foot risk assessment rather than a neuropathy assessment. The foot risk assessment includes neuropathy, and we grade them as low risk, moderate, or high risk. There is no group called no risk. Every patient with diabetes has some risk, and then under high risk, you have people who have had a previous diabetic foot problem or have neuropathy and vascular problems, or vascular problems and a deformity, or so two or more of them. And then there's this group called activists, essentially a group that is ulcerated and we need to do something about a foot ulcer. Now, once you heal the ulcer and you have a healed foot, you don't go back to low risk, even if you can have sensation, you have great pulses. You go back to a high risk group, because once you get an ulcer and you healed it, you're probably at risk for higher ulcers. So the active group can only go down to high risk. It's an important caveat within managing diabetic neuropathy. Actually, my slide is going to be very simple here, because we have no simple ways of managing diabetic neuropathy, and that's been a challenge over the years. Blood glucose optimization is a key factor. It's been shown both in the DCCT, but every other study, that microvascular complications, including neuropathy, the risk of developing that element is reduced with good diabetes control. So in particular, in type 1 diabetes, there is good evidence to say neuropathy development can be avoided or limited. The data is a bit more nebulous in type 2 diabetes, but we cannot but emphasize the importance of glycemic control. This is also a group that shares the risk factors with cardiovascular disease. The ones I showed you earlier, hypertension, raised BMI, dyslipidemia, they are the same risk factors for cardiovascular disease. So it's important to look for and optimize those as much as possible in our patients. But when it comes to true disease-modifying agents, we don't have any, and that's a challenge. FDA and the European Drug Association don't have any licensed pharmacological agents. I think in India you can get all those reductase inhibitors, can't you? I don't know if they're still available, but all those reductase inhibitors which work on the sorbitol pathway have always promised, but it's been difficult to get a meaningful delivery from this group of drugs. And the Cochrane review, it's about 15 years now, at that point of time, concluded that there was no true difference. After that, of course, we've had the Rani-Restat trials, which came out in about 2015. But again, the studies didn't meet the primary endpoint to show a meaningful difference within the two groups that were treated with and the control groups. So we've never really had FDA approval, and we don't use them in our practice here in the UK. So the management of neuropathy includes really glucose control, cardiovascular risk, making sure the foot risk is managed. And of course, if the symptoms become painful, treating the painful symptoms and controlling them. But the pathogenesis of diabetic neuropathy is not just a neural insult at the foot. I think that it's much more complex. There is a peripheral lesion, but also lesions that can happen between the spinal cord and the brain. And you can have abnormalities in the brain. So come together, you can have a lesion anywhere, here, or here, and you can have the development of pain. So it's very, very tricky knowing where the main source of pain generation is. I could talk about that for half an hour on its own. So we do look for neuropathic pain differentials when we see our patients for the first time. Make sure we don't miss treatable things like hepatitis C, etc., or antibiotics, vitamins, and the treatment mainly for us, we go by symptom control, topical and parenteral, various things. I'll cover them briefly. Lignocaine patches is a plaster patch. I found it helpful in acute pain. Sometimes we have young people who have improved their diabetes quite quickly. They get the treatment-induced neuropathy of diabetes. We found this quite helpful in that group. People coming to you with 5 years of neuropathic pain, not found it very helpful. We can use cooling sprays, but they only help cool the area, and there is some randomized evidence for that. And for most severe cases, we have started to use high-dose capsaicin patches, which sort of is like pruning rose bushes. It prunes the nociceptors, the certain channels that drive this. And so we have Cutenza, which is available, I presume, in India too. 8% capsaicin patch is really strong. That is 100 times stronger than the capsaicin cream that we can get here in UK. And we do this as a day case procedure. You apply the patch and leave it on for about 8 hours. And in data, that's me doing one of the patches here. You put it on the foot, and then you wrap it with this light bandage, so that although it's a patch, it doesn't stick very well. So you've got to use something externally to stick it. And then you leave it on for about half an hour. And it's supposed to work its magic in the background and sort of deliver things. We, of course, have challenges in UK with using certain drugs like pregabalin, as you know, is used as a recreational drug too. So the way we prescribe it has changed. We can't just prescribe it. It's a controlled drug. It's a bit like ordering in morphine. So we have to follow different principles. And combination of neuropathic pain agents is now increasingly becoming accepted. Also we need to start recognizing that different neuropathic agents have a different effect size, and often managing expectations of our patients is very important. I often tell them, if your pain is 10 out of 10, it's not a meaningful expectation to expect it to completely disappear. We set the bar at a realistic level. If I can get your pain down to 5 out of 10 in X amount of time, we should consider that a success, etc. There are non-pharmacological agents, and I suspect this is going to be a huge growth area, especially with technology for managing neuropathic pains. And we're going to start a very large study looking at frequency rhythmic pain modulation in our patients with diabetic neuropathy as additional adjuvant therapy to drugs. But I can see this evolving in future as even first line age for people who don't want to use pharmacotherapy. After all, it's got a high NNT, comes with a lot of side effects. So certainly layering treatments might be the future, physical and pharmacological. And spinal cord stimulation is going to be also quite a useful tool where this is possible to it's quite a specialist one. The data for diabetic neuropathy is modest. There's been a large study published last year in JAMA that has shown really great outcomes using high frequency spinal cord stimulation. But remember, you're sticking these electrodes into the spines of people with diabetes. There is always a risk of complications. Using morphine has never been successful in the management of diabetic neuropathic pain. There is some emerging evidence for the benefit of at least treating vitamin D. Not direct evidence, it's more indirect. But my colleagues up in Sheffield have shown that if you have reduced vitamin D, it correlates with greater symptoms. And the management of diabetic neuropathy using supplementations is often discussed. I get asked in meetings, what can you supplement it with? Yes, there is evidence for alpha lipoic acid and certain benfotiamine, etc. But if you get down to the nitty gritty, the target difference has never been met. You have reduction, even sometimes statistically significant, but the clinically significant, meaningful reductions in true neuropathy metrics is unavailable. In some symptoms, co-reduction, yes. But I think this is an area to wait and watch and see what happens. If we have evidence, if you don't have evidence, it doesn't mean that they don't work. We may have to wait and see. But essentially, at the moment, for pain, we tier the pain management into first-line agents, add in second-line agents, and add in certain other agents. And if you really want to manage pain, you really need to sort of have a system in place that is able to monitor them quite regularly, and if needed, put them into have them have regular psychological input and get diabetes pain teams involved. In summary, like in the diabetic foot, a more coordinated approach is required for diabetic neuropathy. Sadly, no disease-modifying agent exists at the moment. And all we can do is ensure there is good diabetes control, good cardiovascular risk optimization, and keep making sure they have good foot risk assessment done. Management of painful neuropathy is very challenging, and making sure you have, you draw good expectations from your patients, I think is a critical element of looking after these patients. And thank you for listening. It's been a great privilege, and I'm really grateful for Dr. Sabu for inviting me to give this talk. Truly delightful. My mother tongue is Konkani, so it's even more lovely to know that you're all having fun in Goa. It's quite wet and windy here in London, so I hope you have a great evening, and thank you very much.
So it was really a very nice presentation on diabetic neuropathy. Can we have a question, short question, please?
Yes, so there is one question in the chat
Yes.
box.
Yes, please.
Yeah, for Dr. Prashvas. What is the role of palmitoy
Ethionamide.
in diabetic neuropathy?
I think I just tried to cover that earlier. I mean, there are lots of these antioxidants that have been touted as an option, as an intervention in diabetic management of diabetic neuropathy. There is no strong evidence to support this. I don't stop our patients if they wish to sort of use supplements, but if you go on a more scientific basis, the evidence to underpin their regular use, if someone is paying good money for it, isn't there yet. Doesn't mean it won't come in the future, but it's limited. There is some biochemical basis for it, but whether, in life, of the 100 drugs that show promise, only one really comes out in the wash. And I don't know which of these antioxidants ultimately will prove to be successful.
So ALA and vitamin D, these are the two actually supplementation should be given.
Any more questions? In that case, I think we are supposed to conclude the session. Am I right, Dr. Chintan?
With the technology to neurology to Antyodaya to Sarvodaya, and really enlightened. And thank you all the speakers. Rajesh bhai, would you like to say the ending words?
Thank you so much. It was really very interesting. All the three sessions were so interesting, and probably mainly the application of digital technology will really revolutionize the diabetic care for all our patients. So nice of you, all of you. Goodbye, everybody.
Thank you,
sir. Thank you.
Thank you.
Very much.